Hey everyone, my name is Mike Hartung from the University of Wisconsin, and I will be presenting on CT of esophageal and gastric pathology. I'd like to begin by acknowledging some of my wonderful colleagues who contributed cases and material to this presentation. We're going to start with the lower esophagus from the perspective of an abdominal imager. With experience, we have come to expect some typical variations of the appearance of the esophagus when looking at the lower chest, starting with the nice, clean, thin, and normal appearance of the esophagus, to the bulging hiatal hernia of various sizes, and to reflux with fluid distending the esophagus. And we have all encountered an esophagus that is simply too thick. When it is smooth and circumferential, relatively low in attenuation, as in this example, you're usually dealing with inflammation and esophagitis. But you also have to be careful about cancer, which may not jump out at first glance. In this first example, it looks a lot like a hiatal hernia. Oral contrast in this second example helps us to be more confident as it displaces the intraluminal air and helps us to appreciate the soft tissue thickening of the wall. And finally, large masses at the gastroesophageal junction with surrounding adenopathy are easy enough to spot. In the emergency setting, things can get a bit stressful when the esophagus is thick and has air outside of the lumen. This is an example of esophageal perforation as a result of repeated vomiting, also known as Boerhaave syndrome. And we all know what follows that diagnosis: a request for a fluoroscopic esophagram. These requests can be a bit painful to handle, especially after hours. It can feel like a mess with sick patients, limited ability to drink contrast, and difficulty with positioning. But this is an important triaging tool to look for the size of the leak, which helps direct cardiothoracic surgery to know if the patient can be managed conservatively or needs surgical repair. Here is an example of a patient presenting urgently to the emergency department with a thickened, hemorrhagic esophageal wall with pneumomediastinum. Clearly there is a leak, and CT surgery wants us to do an esophagram to find and characterize the leak. So I took the patient back to the fluoroscopy suite, but for the life of me, I could not find the injury. This picture may overall feel familiar to you: a larger patient, poor penetration of x-rays, and challenging with positioning, limiting the sensitivity of the exam. So I improvised a bit and called our CT techs and had the patient brought over for a limited CT of the chest after having him drink a bit more on the table before the scan. And after seeing the leak on CT, it's hardly a surprise to me that I couldn't see it in fluoroscopy, as it projects posteriorly, overlapping with the spine, and had a relatively thin and subtle channel. And now at our institution, this useful workflow has been formalized, and it is called the CT esophagram. It starts by having the patient drink about 100 cc's of liquid on the table immediately prior to performing the chest CT. The liquid is comprised of about 75 mL of water and 25 mL of contrast. This study is better at detecting small leaks, gives us more information about the nature of the leak, and helps keep our workflow more efficient during daytime and after hours. Let's take a look at some other examples of a CT esophagram. This patient had a tracheoesophageal fistula related to radiation therapy and underwent our CT protocol. The images clearly show the thin channel of communication between the esophagus and left mainstem bronchus, with contrast filling the distal airways in the left lower lobe. This sagittal off-plane reformat shows contrast within the esophagus here, and the thin channel of communication with the left mainstem bronchus. Using the CT protocol, we were able to make a confident diagnosis and help to guide treatment with esophageal stenting. This next example patient presented with chest pain after esophageal dilation due to chronic strictures in the setting of systemic sclerosis. With this exam, we can not only rule out even a relatively subtle leak, but we also get a sense of the overall esophageal anatomy and length of the stricture and degree of wall thickening. Here are 2 tips if you're considering adopting CT alternatives to fluoroscopic procedures like this one. First, develop this kind of procedure in conjunction with your major orderers. In this case, that was the emergency department and cardiothoracic surgery. We did this so that we had universal buy-in. Second, while it might seem obvious, if you adopt something like this, give it the same name or a very similar name as the fluoroscopic order you are trying to replace to improve ordering recognition and compliance when they're using the electronic medical record. So that wraps up the esophagus, and it's now time for us to continue our journey below the diaphragm and cover the important gastric pathologies that you should be aware of. As you all know, the stomach can vary greatly in appearance depending on when the patient last ate or drank. This changes our ability to see the normal rugal folds of the stomach as it stretches out. But over time with experience, we all get comfortable with that range of normal. When the stomach is relatively scrunched up, you will see rugal folds fairly well, like in this example. And when the stomach is full, like in this case, where it's distended with oral contrast, we barely see any of the rugal folds because they're effaced. Of course, the real diagnostic dilemma comes in when the wall becomes too thick or may be too thick. And generally speaking, we know too thick when we see it. So let's spend some time considering the causes of increased wall thickness and how to make appropriate recommendations for further management. For our first case, the gastric antrum is clearly too thick, and it especially stands out compared to the rest of the stomach wall. But what do we think? Is this inflammation or is this cancer? Well, first, notice how it's relatively low in attenuation. This indicates edema and inflammation are the primary cause of increased wall thickness. And indeed, this patient was referred to gastroenterology and underwent endoscopy, where they found several superficial ulcers in the gastric antrum. There are some other scenarios where we see the similar pattern of low attenuation wall thickening. Subacute and chronic pancreatitis are 2 common scenarios when the gastric wall gets thick due to edema and inflammation. Here's a patient with extensive low attenuation gastric wall thickening related to chronic gastritis in the setting of chronic calcific pancreatitis. In this case of subacute pancreatitis, pseudocysts are dissecting into the wall of the stomach, compressing it and resulting in inflammation. There are also pseudocysts burrowing under the splenic capsule, causing compression of the splenic parenchyma. And in this case of necrotizing pancreatitis, the stomach is displaced and severely inflamed and thickened as a result of infected walled-off necrosis, with both low attenuation edema and mucosal hyperenhancement. This degree of gastric inflammation as a result of the walled-off necrosis was new and helped to raise suspicion of underlying infection, which was ultimately treated by gastroenterology with cystogastrostomy tube placement. But low attenuation wall thickening doesn't always have such a dramatic presentation. This is a younger male patient who presented with vague abdominal symptoms and CT findings of gastritis. After extensive workup, this turned out to be the rather uncommon Menetrier disease, which is a rare type of hypertrophic gastropathy resulting in hypoproteinemia. So now we've covered some of the major inflammatory causes of increased wall thickness in the stomach, and now it's time to consider how we handle a potentially associated finding of air in the wrong place, starting with perforation. For gastric, pyloric, and proximal duodenal ulcers, you will see a characteristic pattern of free air in many cases. You'll see air in the anterior abdomen, in front of the liver, in and around the gallbladder fossa, and there is often associated fluid. You may not always see the ulcer crater, as it becomes small after it decompresses and perforates, and the surrounding edema often presses it together, making it hard to see, but the pattern of air, fluid, and inflammation will help to guide you. Oral contrast can be great for helping you locate the perforated ulcer and should be considered for your initial exam or for problem-solving challenging cases. It is helpful if the patient is even able to drink a small amount of contrast. In this case, contrast is leaking through this antral defect and coating the liver edge, helping us to make a confident diagnosis about the location of the perforation. This patient had free air, peritonitis, and could not receive IV contrast. He did drink some oral contrast before CT, admittedly more than was needed, and we can see some of that contrast that leaked out layering along the lateral and lower liver edge. The coronal images clearly show the thin channel of contrast leaking from the perforated pyloric ulcer, which helps to guide surgical repair and avoid a larger midline incision if the site of perforation remains unknown after CT. An important variation of perforated ulcer to be aware of is called a marginal ulcer, which occurs in the setting of gastric bypass. These are often subtle and can be easy to overlook in the upper abdomen with all of the postoperative changes. However, in this case, we start with a high degree of suspicion of a perforation due to free air in the upper abdomen, and as we look carefully, we can see some subtle stranding near the gastrojejunal anastomosis. Taking an even closer look, we can see the inflammation and dots of air at the gastrojejunostomy. Marginal ulcers typically occur at the jejunal side of the gastroj. The operative report confirmed a 1 centimeter perforation just beyond the gastroj, which was treated with an omental patch. But air outside of the stomach wall isn't the only thing to be concerned about. Air in the gastric wall, which is also known as emphysematous gastritis, is caused by gas-forming infection with or without ischemia of the gastric wall. On endoscopy, this patient had extensive ulceration with necrosis and ischemia, but did have healing on a repeat evaluation a few months later. Gastric varices are usually not a diagnostic dilemma, but they do have some important associations to be aware of and can simulate increased enhancement of the stomach wall in some cases. This first example has numerous submucosal varices in the setting of portal hypertension. And this second example has some short gastric varices coursing through the posterior fundus. We'll scroll down a bit in that second example to look for the cause. Here we find a pancreas tail adenocarcinoma, which is occluding the splenic vein. This results in venous collateralization through the short gastric veins and into the stomach. So now that we've covered several inflammatory and infectious gastric pathologies, we're going to have to address the really bad actors in the bunch. It's time to talk about cancer. We'll start our conversation by going back to wall thickening and expanding our differential beyond inflammation alone. As you know, inflammation of the stomach wall is relatively dark, indicating edema. Lymphoma infiltrating the stomach wall will have more intermediate attenuation wall thickening and often looks relatively bland and featureless without clear distinction of the mucosa or the media. Adenocarcinoma, particularly the infiltrative type or Linitis plastica, is often bright and enhancing, and in this case has a similar brightness to the intraluminal positive oral contrast. Gastric lymphoma can result in varying thickness of the gastric wall and can even get quite bulky, as in the second example. In keeping with the old adage, it does in fact usually not obstruct. This is due in part to the impact on the myenteric plexus of the wall of the bowel, resulting in a common cavitary appearance despite the presence of bulky disease. This third example is a bit tougher to sort out as there's both tumor and ulceration. You can start to distinguish the two by noticing the edema along the upper margin flanking some soft tissue and a larger component of soft tissue or lymphomatous infiltration along the lower margin. This combination of edema related to inflammation and adjacent soft tissue helps to highlight the difference in density and how that helps us to make the diagnosis. Stomach infiltration is usually not the only manifestation of lymphoma. It is very helpful to tie it all together by looking for hints in the other organ systems. So if you're puzzling over a stomach finding, take a break and complete your search pattern by looking for adenopathy, organ infiltration, or other sites of disease in the remainder of the GI tract to help you make the diagnosis. Let's move along and discuss adenocarcinoma. Linitis plastica is an infiltrative subtype of gastric adenocarcinoma which results in diffuse thickening and enhancement of the wall. It can be primary or metastatic, and it can start as relatively subtle, like in this first example, where there's only some asymmetric increased thickness and enhancement of the posterior gastric wall, and progress to extensive thickening, which was seen 4 months later in the same patient. This third example of more extensive disease shows adjacent lymph nodes between the lesser gastric curvature and the liver edge, supporting the diagnosis of adenocarcinoma. When you're concerned about gastric adenocarcinoma, often you don't have to look much farther than the gastrohepatic ligament for clues. Normally, there is just fat between the lesser gastric curvature and liver edge. And remember, you cannot distinguish normal ligaments from fat on CT. You can only distinguish them when they become diseased. It's important to get comfortable with this location and recognize it as one of the first places that bad lymph nodes and thickening end up for gastroesophageal junction and gastric adenocarcinoma. Let's practice with this case of abnormal gastric wall thickening. What do you think is the most likely cause? Gastritis, lymphoma, or adenocarcinoma? In this case, the stomach wall is diffusely thickened and has some areas of increased enhancement and also some areas of edema. There's also a lot of ascites, so what diagnosis should we favor? There is soft tissue thickening and nodularity outside of the gastric wall, which helps us. This is creeping along the gastrohepatic ligament here. And what do we make of all of this ascites? Ah yes, the omentum in the left upper quadrant. This is thickened with implants flapping around in the ascites. Even this relatively subtle amount of thickening of the omentum is highly suspicious, so be sure to scan the entire peritoneal cavity carefully when dealing with cases of suspected gastric cancer. This patient has peritoneal carcinomatosis. And when you're dealing with gastric cancer, you must become comfortable with catching carcinomatosis in its varying presentations. It isn't always obvious, but an advanced presentation of carcinomatosis like this would certainly be a giveaway and highlights the key features to look for. Here we have ascites, extensive omental caking, and nodular infiltration of the mesentery. Departing from classic presentations, it's also important to be prepared to think outside of the box and recognize new patterns of peritoneal disease beyond just omental cake and ascites. This patient has linitis plastica with infiltration of the gastrohepatic ligament, but also has an unusual pattern of peritoneal disease with coating, nodular gallbladder metastases here, long segment biliary nodular metastases, and also implants here along the bladder dome. And this patient had a large, lobulated, and infiltrative gastric mass with many omental nodules, and a third important finding in the pelvis: bilateral ovarian metastases, which are also known as Krukenberg tumors. It is important to become comfortable describing abnormalities of the afferent limb in the setting of gastric bypass patients. Using simpler terms, the afferent limb is the excluded stomach and proximal duodenum and jejunum, which later connects with the roux limb or alimentary limb at the jejunostomy. The excluded stomach should normally be relatively small and decompressed, but when obstructed can become quite dilated, as in this case. It is often helpful to draw out your understanding of the anatomy and where the problem is. To refresh, bypass anatomy includes a roux or alimentary limb. The majority of the stomach is excluded, and these gastric secretions, along with the bile and pancreas enzymes, known as the afferent or hepatobiliary limb, travel distally to the JJ anastomosis. Obstruction can occur along the outflow of the afferent limb and can cause afferent limb syndrome or afferent loop syndrome, which can happen due to adhesions, mechanical abnormalities such as stricture, internal hernia, or even cancer. Afferent limb obstruction often leads to confusion in management, especially if you're interacting with a trainee or inexperienced resident. They hear you say obstruction and reflexively will reach for the nasogastric tube. But the NG tube does not work in this case because the afferent limb obstruction occurs with bypass anatomy and the roux or alimentary or antegrade limb is usually fine. It is the excluded stomach or the pancreaticobiliary limb that is obstructed. So I like to make this very clear when I'm reporting. It is worth a phone call to directly tell the team that the patient has bypass anatomy and that the NG tube will not address the problem in this case. In your impression, it's often helpful to describe the afferent and roux limbs separately, or even use simpler terminology like excluded stomach / hepatobiliary limb or alimentary limb for the roux limb so everyone is on the same page and comfortable with what is happening. Let's go back to our patient. This patient presented with a several-day history of worsening abdominal pain, and the excluded stomach is severely dilated with some thickening near the pylorus. The coronal images really help us appreciate the degree of gastric distension, which is quite severe. This patient had an emergency venting G-tube placed and eventually underwent pyloric biopsy, which confirmed an obstructive adenocarcinoma within the afferent limb. Let's wrap up adenocarcinoma with a slightly more subtle case of wall thickening. Remember that adenocarcinoma will usually leave some clues. So what do you think? Is the lesser curvature a little too thick, or is that just due to underdistension? Notice how it looks more soft tissue attenuation than low attenuation or edematous, and that the stomach is pretty distended with oral contrast, particularly when you compare the coronal image, where the greater curvature is thin and the lesser curvature becomes quite thick, even with an irregular border. Well, we don't have to scroll very far in this case to help us sort it out. Scrolling a bit inferior, we spot these two huge gastrohepatic ligament lymph nodes, which support a high suspicion of gastric adenocarcinoma, which was confirmed in this case. Let's wrap up our discussion on tumors by touching on some other important presentations. Gastrointestinal stromal tumors can occur in the stomach and small bowel. In the stomach, they tend to form well-defined, rounded submucosal masses when they're small, but they can grow quite large and bulky, as in this case. Carcinoid tumors, or neuroendocrine tumors of the stomach, are rare, but having a biphasic protocol, which highlights the arterial hyperenhancement, can be particularly helpful in detecting them. And finally, this case of a patient with congenital polyposis has diffuse thickening of the stomach related to numerous gastric polyps. All right, we did it. So let's now wrap up with some highlights of the material that we've covered. Starting with the distal esophagus, we can evaluate wall thickening and differentiate inflammation, cancer, and perforation. CT esophagogram is a helpful alternative to the fluoroscopic study and can provide more anatomic information, higher sensitivity for leaks, and be easier on busy daytime and after-hour workflow. This could be developed in conjunction with the major orderers, usually the emergency department and cardiothoracic surgery. Two common causes of gastric inflammation are related to pancreatitis and peptic ulcer disease. When gastric or proximal duodenal ulcers perforate, you will usually see a predictable pattern of air, fluid, and inflammation to help you be confident about your diagnosis. And less common gastric pathology includes emphysematous gastritis and Menetrier disease. And finally, remember that the density of the gastric wall thickness will help you differentiate inflammation, lymphoma, and infiltrative adenocarcinoma or Leionitis plastica. Cancer will usually leave clues such as gastrohepatic ligament adenopathy or carcinomatosis. Other important gastric tumor types to keep in mind include gastrointestinal stromal tumors and carcinoid tumors. Thank you for your attention, and I hope you've enjoyed this talk. We've covered a wide variety of high-yield pathology, and I hope this helps you in your practice. Many of these cases are available at this QR code in a Radiopedia playlist if you'd like to get some additional practice or review the cases that I've discussed. You can scan this with your smartphone camera app. I'm happy to hear from any of you via email or later in the conference. Thank you again.